Okay, it is 10 o'clock, so we will go ahead and get started. Welcome, everybody. Thanks for being here for our first informational only CoC meeting of the year. We know that you have lots to do in your roles and everybody is stretched to full capacity, so we appreciate you taking the time to learn a little bit more about behavioral health and physical health resources in our community this morning. We are not going to do introductions since there are quite a few of you with us, but feel free to go ahead and introduce yourself in the chat. We are recording, so if you have staff who aren't able to attend and would benefit from this information, we will share the recording link later so that you can share that out with your staff. We do have quite a few CoC board members with us this morning, as well as providers and direct service staff that are with us. So thank you again for being in attendance today. We have quite a few presentations, so we're gonna get started, but we do have time for questions and discussion in between each presentation. We are going to kick off this morning with Pinellas County and the Department of Health, and they are going to talk to us about their healthcare for the homeless program. So I will let Dr. Barnett and Melissa introduce themselves and share a little bit more about that program.
Hi, good morning, and thank you, Amy. Thank you for having us. I'm Joshua Barnett. I'm the healthcare administrator with Pinellas County Human Services, who works under the direction of Ms. Karen Yatcham, who's the director of our department, and I'm joined by Melissa Van Bruggen, who is the clinical health services director for the healthcare for the homeless program. I'm going to now share my screen. Can my screen be seen? Great. So what we want to do for you today is just provide an overview of the healthcare for the homeless program as it relates to our clinic services, discuss about the population that's served by the program, and then Melissa will be speaking about the services provided and what our plans are for the future with this type of service. This program is funded by the feds at HRSA, which is the Health Resources and Service Administration. And they provide a variety of funding opportunities across the country to really optimize access for individuals who are either in poverty, who live in communities that have decreased access due to the rural nature of their community, seniors and other individuals. We are fortunate to have this funding. And so with our local contributions provided by the County Commission, we're able to receive additional funds from HRSA at nearly $5 million a year to help make sure that we can provide ongoing access for those who usually have disparities in access based on their homeless status. The goal of the program is really to help address a lot of the health and chronic disease conditions that are usually adversely experienced by individuals who are homeless. So you can see on the right-hand side, the difference between those who are homeless versus not in terms of the prevalence of significant diseases that affect quality of life or impact our local community in other ways. And so really the goal is to prevent unnecessary hospitalizations by equipping them with multiple access points in order for them to receive preventative or health home services to manage those chronic diseases or identify them altogether so that it can be managed more holistically. And we do that by providing them multiple access points throughout the county so that they can receive that type of care. The program is intended to serve individuals who are homeless, regardless of their ability to pay, so that limited financial resources are not a barrier to accessing necessary medical care. We currently have over 3,000 individuals who are enrolled in this program throughout Pinellas County. This program has been around for a while, starting with a mobile medical unit pictured here, which is really bringing care to people in their communities. And that started back in 1987. And then just beneath that picture is a photo of the Bayside Clinic, which opened in 2016 and continues to expand today, which you'll hear Melissa speak more about. And the hours include standard day hours, including evening and some Saturday hours, because we know that healthcare doesn't always operate on a business schedule, but really we want to make sure we're providing access to folks in locations and at times that's most convenient. I'm going to then finish my section by just speaking about the population we serve. There is an online application in which agencies and community partners or individuals themselves can access so that they can receive a gateway into our services through an easy eligibility process. This is really targeted for individuals who lack housing. So if they live with an individual member or with a family, we don't want that to be a barrier. They may not have a permanent ongoing place to live, but they may spend the night in a private care facility who might provide them some temporary sheltering. They might live in some transitional housing, or they could be moving into some supported permanent housing. But if they're still considered in our population, we want to make sure they can get served. So as they're working on their other social determinants of health with housing, we don't want that to be a carve out or a barrier to maintain their continuity of healthcare. And also we serve those who are formerly homeless. So there could be, someone who has been served. We don't want to disrupt their continuity of care as they've already worked and engaged with our clinic services. And so we want to maintain our care relationship with them. If there are children and youth who happen to be related to the individual, we can refer them to another federally qualified health center with our partners with EVRA, and also look to obtain additional resources for homeless veterans or veterans who are at risk of homelessness. And I will end my portion of the presentation by saying income, again, it cannot be the barrier. There may be subject to sliding scales, and then we apply a waiver of fees so that those who are trying to earn income to obtain stable housing or take care of other needs, health continues to be something they can access. It's for individuals who are adults, so 18 to 64. And the reason that is because if you're over the age of 64, you may be entitled to other benefits because of age, but while you're waiting, we'll still continue to serve you. And there's additional benefits that we can look into or assist with as well as people are leaving correctional environments, people who are receiving workers' compensation as a result of injury, and then other benefits to assist them. That's the end of my portion. I'm going to turn it over to Melissa to speak about the services. Thank you.
All right, good morning, everyone. So I'll tell you a little bit more about the services we provide, both on-site at the clinic and in our mobile medical unit, and then also through partnerships in the community. So to start, we of course provide primary medical care. So we are, you can see the little logo on the bottom, we're a patient-centered medical home, which really means we put a focus on quality and patient-centered care. So it's a national recognition that we've had since 2016. So as a patient-centered medical home, on site, we're doing all the preventive care, treating those with chronic diseases, acute and episodic care, physicals, immunizations, lab work. So we have a lab on site at Bayside. On the mobile medical unit, we can draw labs as well, or our patients also have access at any Quest location as well. We do, in addition to kind of the routine primary labs, we do STI and HIV testing as well. In the past year, we've started providing HIV PrEP services. In addition to that, as far as prescription coverage, our clients do have access to a network of around 200 pharmacies, kind of all the major retail pharmacies. They can get their prescriptions at no cost. We also have prescriptions assistance navigator on site at Bayside to help them with the prescription assistance program, another resource for getting medications at no cost for them. We have nutrition education and counseling that's available through a registered dietitian through the Department of Health. Care coordination or case coordination, we have an on-site RN that does care coordination. So she helps all of our patients with chronic diseases, kind of helping them manage those, education, care planning. As far as behavioral health services go, our patients have access to a wide array of services through partnerships. We have two kind of main community partners, Directions for Living and Operation PAR. So Directions, it does treat our patients with mental health and or co-occurring mental health and substance use disorders. We do have a Directions APRN on site at Bayside, and she is also going to some of the mobile medical unit locations as well, trying to get the care out to the patients. And then with Operation PAR, they are a provider for most of our substance use services with a focus on medication assisted treatment for our clients. As far as specialty care, our clients also have access to a wider array of specialists. I think we have over 100 specialists as part of our network that they can go to. So that's all again covered for them. You know, if they end up hospitalized, procedures, surgery, all of that is covered as well. Really, the only thing not covered is really ER visits, because that's what we're here to prevent, and hoping they're coming to us for that. COVID, we are still doing COVID services. So COVID testing, both rapid and PCR testing, you know, ongoing vaccination effort. So we do those at the clinic, but we also have funding for a vaccine ambassador program. So we're also out in the community trying to get out and reach the homeless that may not be coming to the clinic, providing vaccinations, COVID vaccinations, but also, you know, all the other vaccinations as well, or hepatitis, pneumonia, Tdap, flu as well right now. Last but not least, oral health is one service we provide as well, on site at Bayside. So we have, you know, we do all the prevention type services from cleanings all the way to restorative, including dentures. So dentures are done on site at the Bayside Clinic. All right, so here's a slide just showing you a little bit about our patient volumes. I think like a lot of healthcare providers in the community, we have seen a downward trend in the past couple of years. So on the medical side, last year we saw just under 2,000 patients, down a little bit from the past couple of years. So at our peak, we were just under 3,000. And dental side, kind of similar, we were up to just under 1,000 and then down to just under 700 in 2021. So of course, we think a lot of this is attributed to COVID related reasons. You know, we never closed our clinics. Dental was somewhat limited in 2020 for a time, you know, to emergency services. You know, but we saw just a decline in enrollment into the program, people coming in, you know, we were doing a little more telehealth or spaced out appointments. Our mobile medical unit was impacted, you know, not going out to all the sites as well. So this is one area, time permitting at the end, we were hoping for some dialogue on. We'd love to hear from everyone and kind of what you're seeing as far as access to care. You know, are patients going, not going? Are they accessing care elsewhere? So we'd love to hear feedback there. Behavioral health, that's been a little bit more stable. You see a blip there in the blue line. That was a few years ago in 2017. The county did have kind of an extra grant, a grant through AHCA, the Agency for Healthcare Administration, to do some additional services for that time. A lot of it related to kind of connection to ongoing care. So that's why you see that large blip there. But really over the past few years, things have luckily remained pretty stable. 498 patients served for mental health and 169 for substance use in this most recent year. All right, and what's coming up for the program? So got a few things we're pretty excited about. The first there, technology. So we have been doing some telehealth, but really looking to expand that. I mean, I think everyone's seen how valuable and needed that is, especially in the past few years. So there is some funding to kind of help expand that, get more access points out in the community. We know a lot of our homeless clients may not have direct access to the equipment. They would need to do telehealth. So kind of creating some access points for them in addition to coming into the clinic. We did get some funding for hypertension related to blood pressure self-monitoring devices. So our patients right now with hypertension are being issued their own blood pressure monitors. Eventually their readings will import directly into our EHR, so we can monitor them remotely and kind of help them manage their hypertension, even if they're not able to come into the clinic. As far as our mobile unit, some might be familiar that we've had some challenges recently as it's sort of nearing the end of its useful life. So we're very excited that the RFP process has been underway for a new mobile unit. So again, just like everything else in the world, there are some delays, but we're hoping in the next year or so we will have a brand new mobile unit. And probably one thing our staff are most excited about is our clinic expansion. So we'll have over 2,000 more square feet at Bayside. So very excited about that. New exam space, some negative pressure rooms to help with things like COVID or hopefully not, but any other communicable disease type outbreaks. Also, we'll have another dental operatory, expanded room for behavioral health, so we can have on-site services more frequently. Again, that will be a kind of a longer term project, probably a couple years of construction, but very excited about that. And last on the list there is street medicine. So the county received some funding to sort of expand our services. So that will have a medical, dental and behavioral health component. So we're just sort of in the planning and hiring stages for that, but we're excited to try to bring some care out, mostly focusing on the unsheltered homeless that we're not seeing coming in. So going out to them and engaging them in services. So with that, I'll turn it back over to Joshua.
Thank you, Melissa. And thank you again for having us. I think just in summary, our idea is to continue to reduce those barriers, either for the people who have transportation issues, financial barriers, and making sure that we provide a wide variety of access points using technology, mobile medical units, and a variety of site-based clinic spaces. And we just continue to need help about how do we integrate and partner about getting people into care, prioritizing primary care and specialty care, and anything we can do to assist and partner and share what we're looking to do along with our robust FQHC services, we're always happy to hear. So thank you for your time and thanks for this opportunity to speak with you all.
Thanks, Melissa and Joshua. We did have one question to come in. Councilmember Beckman asked if you feel like you have adequate resources and staffing for the level of care that you need to provide. I'm probably summarizing that a little bit, but I think, she's trying to understand, does the need and resource match?
So I think we start to explore about how do we integrate with people. So in our street medicine program, it's really about how do we continue our operations and get people to our site-based clinics so our utilization is down, but the need continues to increase. And so we're really trying to be thoughtful about how we access and ways in which we communicate and bring care to people. And as we learn more about that, particularly with our telemedicine and our street outreach program, I think we'll have a better understanding of how we continue to address the need. There always will be gaps. And so I think we just want to be thoughtful about what those specific gaps are as we continue to learn more about working with people in their environment, and then also expanding our array of services and partnerships with our hospital so we can ultimately keep them out of the hospital, which is probably our primary area of need. So there might be some greater opportunities in those types of partnership arrangements.
Okay, other questions? I did put a PDF of the slides in the chat, and I'll be sure to send everybody's slides out afterwards. And if you don't have questions, it sounds like the county would like some feedback from you as well about, are your patients accessing care, and are there opportunities that they can assist?
Yes, we really would like to hear more about that. And we look forward to sharing our telehealth technologies too, to feel how we can more fully integrate with you all to serve our shared population.
Yeah, I just had a question. Can you hear me?
Yeah.
Okay. Hey, good morning, and thanks for your time. This is Chris. I was wondering if you're engaging with a new, patient that you're providing care for, and you identify them as, currently homeless. Maybe they are a transient, so they're new to, our community in Pinellas County. What is from a continuum of care, you would become basically the first point of contact. Are you putting them into a database like the VI SPDAT or I think there's a HMIS system, homeless information system? Is that part of your process?
It is, and also our department has recently added a position for a homeless services section manager who is continuing to optimize our interface and use of those resources, because ultimately we know that we share care a number of times. And so by looking to see where they are in the HMIS system, to look to see where they're being served elsewhere, if we have any gaps in care within the clinic can then access that service and then more fully partner with the agencies that they're receiving services through, or direct them to those other services, because we know that health is just one small component. And then we're also looking internally about behavioral health care utilization, so that we can return that person to a health home so their health can be more fully managed. with some of that case coordination, rather than the person having to sort of access services disparately or episodically, where no one's really talking about their full needs. So we're looking into that as well. And so we actually just had a similar conversation this week.
Okay, cool. Yeah, I was just looking to learn more about how that works. So that sounds great.
And Krista shared just a little bit more. So individuals, there's different flows for individuals and families when they should be VI SPDATed. And so for an individual, even though they may be entered as a service at Bayside Clinic, for example, they may not be VI SPDATed immediately because there's a certain number of touches that need to happen and that kind of thing. So, and that's different for each population. So I wanted to explain that because as a new board member, you wouldn't know that we have different policies around when an individual is assessed and when a family is assessed, for example.
Okay. Thank you.
Kathleen Beckman has another question about any demographics that might be able to be shared. Are you saying the majority of people coming from Clearwater or St. Pete? Do you have reports on average age or any other demographics for the folks who are using those services?
Yeah, I can help answer that if that's helpful. So because we are a federally qualified health center, we have UDS reporting that is due each and every year that really is every possible data point. And we publish that on our site. We also can share that with this group, but it really does look at zip codes, race, ethnicity, sexual orientation and gender identification. But that is something that we can share with this group, but it is a significant report that is due actually in 11 days. So it's due February 15th of every year.
And then I see Victoria is asking if there are handouts that can be given out during outreach.
Absolutely. Can I share them with you, Amy, for the group?
Yeah, absolutely. Okay. And then Teresa is saying that she loves the idea of expansion into street health services and thanking St. Anthony for providing a nurse that helps the PATH team in St. Pete. Any other questions or comments about access to services?
All right. Well, again, on behalf of the Department of Health in Pinellas County and the Bayside Clinic and our Healthcare for the Homeless program and here at Pinellas County Government, we appreciate your time and look forward to working with you all more.
Thank you so much. Super helpful. And I have to say, I'm really excited about the expansions through the ARPA funds. So, you know, we know that it's much needed, especially dental support. And also just want to say thank you to Melissa in particular. She's been on a long road with our CoC during the COVID hotel and, you know, all the vaccinations and everything else. And we're thankful for support from the Department of Health as well. Okay, next we are going to talk about medical respite care, and we have Stacy Galick, who is a CoC board member who is going to share a little bit about their programs. I want to say, you know, one of the things that helped prompt this meeting, we knew that there were more folks who could be accessing healthcare for the homeless. And I learned during the need for somebody to have some respite care. I've been on the board prior to serving this as the CEO and didn't realize that not every hospital has the ability to put people in respite. And I asked other CoC board members, I said, did you know that? And they said, no, we thought everybody had access to this. So that was a part of why we wanted to talk about respite care. Baycare is doing their part, but we know that we need other hospitals to join the force so that all of our clients can be taken care of. And we're starting those conversations as a community to replicate that model with other healthcare providers. So we're really thankful for the work that Baycare has been doing, and I'm going to turn it over to Stacy.
Excellent. Good morning, everyone, and thank you for asking me to join this meeting. Are you all able to see my screen?
Not yet.
Okay, let's try this again, because I see it on my end and I hit the share screen and let me hit this and
Now there you go. You're good.
okay, excellent. And let me play it from the slideshow. So thank you, Amy. Yes, I am the West Region Director for Hospital Care Coordination, Inpatient Case Management for Baycare's hospitals in the West Region. So I have Pasco and Pinellas County Baycare hospitals are under my umbrella. And our first support for homeless medical respite is our partnership with Pinellas Hope. I think many of you are familiar with Pinellas Hope. It's sponsored by the Catholic Charities. However, St. Anthony's Hospital Baycare does fund and provide the healthcare services through Baycare funds and also grants that we receive from the San Franciscan ministries. Dr. Sandra Grosvenor is our coordinator on site at Pinellas Hope. And they usually have on average about 300 to 400 residents on any given day. Their medical respite program can accommodate 10 people who are discharged from hospitals. Just to clarify, Pinellas Hope will accept, medical respite patients from all sources, not just coming out of Baycare hospitals. But our Baycare Home Care, home health care agency will also provide services to the medical respite patients if they are in need of home health care type of services that Sandra, is not able to provide. And hot off the press, Sister Mary from St. Anthony's shared with me last evening their 2021 report. And with the team and the services on site, last year, they were able to prevent 69 EMS ambulance calls to Pinellas Hope. So obviously that is a win, not only for the client who can remain stable, at Pinellas Hope, but also allows EMS to then divert that ambulance to another need in the community. Sandra and her team did 249 med reconciliations, 1,107 nursing assessments, but a total of last year of over 2,000 nursing encounters. So that might have been things like education, so on and so forth. She also provides Go Healthy classes there at Pinellas Hope. 46 were offered last year and 306 clients attended, along with hand washing and other basic, sort of healthcare education opportunities. They also do CPR on site for training for their staff. So we're very proud of our relationship that we have with Pinellas Hope, but recognizing that not all individuals meet criteria under the qualifications for Pinellas Hope. And so my counterpart in our East region, Lindsay North, actually spearheaded a relationship and developed an agreement with Salvation Army in St. Petersburg. We also do this in Tampa as well. And just in the last couple of weeks, opened our other relationship with their Winter Haven Salvation Army. So we, Baycare, we lease 5 medical respite beds and then 3 separate bed leasing arrangements from our behavioral health division. So a total of 8 at our Salvation Army St. Pete location. And then again, Baycare Home Care will go on site and provide home health care services for our patients at the shelter if there's a home care need for a skill. We are waiting for our report from the Salvation Army for numbers served in 2021. I did a rough estimate. I think we were around 75 Baycare hospital patients that were served in the medical bed leasing. The 3 beds from the behavioral health side, I don't have access to that information just yet. So, but this has been a huge win for us. It allows us to free up hospital beds in our hospitals throughout, the COVID surge, and still providing care for everyone else with your routine medical needs, your heart attack patients, your strokes, et cetera. Having beds available in our hospital to meet the community needs is at our utmost importance. And by shifting our patients who are ready for hospital discharge but are homeless, but still need mild medical oversight or intervention, this has been a great resource for us, to continue to meet those clients' needs, but open up our hospital beds. And this, I didn't include this in my slide too, Amy. I just popped this in at the last minute. If any of you have any other questions or would like to know a little bit about how we engaged with Salvation Army to create those bed leasing arrangements, we are happy to talk with you. Questions for me? All right.
Okay, I see one question, trying to understand the difference from respite care that may be the type of respite when a caregiver is taking care of someone versus this type of respite. And so Stacy, do you want to just kind of describe what we mean by respite when we talk about it in the homeless system?
Yes. So these are patients that are truly ready for hospital discharge. They don't need to, meet that level of care. However, they still have needs that's not appropriate really to be met just if they choose to be in the regular shelter population, or even if they choose to go back onto the street. So this is things like IV antibiotics, simple wound care, might be new oxygen therapy for just a little while where they need access to electricity to run the oxygen tanks until they can be weaned off of that. And so that is where having a bed available, a safe location, and a bed available for them to safely discharge from the hospital into that safe setting where we can then provide that medical wraparound service that they need. And so it's a little different than providing sort of caregiver respite for someone who's a primary caretaker. Let's say for someone with a memory disorder, Alzheimer's, or dementia. There are some other programs in the community to help, those individuals. Caregiver burnout, especially during COVID, was a very big concern, and so that is a little bit of a separate issue than what we're dealing with here with our homeless patients that need that medical intervention.
Perfect. Thank you so much, Stacy. Questions or comments about medical respite? I know recently the CoC has started to have some conversations, especially I think my most recent report shows that those over 55 in the continuum of care just in the last year has gone up 730%. And most of our shelter services, aren't the best type of services for someone who may have chronic health conditions or may not be ambulatory or other things. And so this, as we have more seniors becoming homeless, this is going to be, a continued part of our conversation.
Yes. All right, I will stop sharing and turn it back over to you all. Thank you so much for having me this morning.
Thanks, Stacy. I'll mention one provider that we did not get for this presentation, and maybe we'll have them do something in the future. Just like hospitals have to bid on expanding services with the state, so does hospice care providers. And one of the hospice care providers that recently won an expansion to our area, a part of their bid included providing housing when someone is at their end of life. So if anyone has a client where that kind of need comes up, we are able to make that connection, and then they provide the financial resources to help house that person during their last days. So that's another resource that most folks don't know about. So, let us know if you have a specific need like that. Okay, another one of our.
Amy,
Teresa?
hi, this is Lottie.
Oh, hi, Lottie.
I definitely would like to know more information about that.
Okay. Absolutely. Okay, I think up next we have another one of our Department of Health rock stars that has been with us for a very long time, but has been especially engaged over the last couple of years. So I'm going to turn it over to Gail. I know when I asked her if she would be available to talk to us, that folks might want a COVID update. she said, sure, and she'd be happy to talk HEP or TB or any other disease that we would like to talk about. So I'm going to turn it over to Gail.
Hi, good morning, everyone. So I hope you can see my screen. What I'm attempting to do today is talk a little bit about diseases of concern to the homeless population. So in the past, we've had, presentations at the board meetings to talk about these things. So today I'm just going to talk about everybody pause and sigh, COVID at the start, and then we're going to go through some other diseases. And I'm hoping that Amy will allow me to come often enough to the meetings to just provide updates to let you know what might be diseases of concern. So this is a slide that represents the Florida cases of COVID. It is now very relevant to understand that the peaks are representative of the different variants. So now that we know how this disease is working, we're seeing the different peaks, and we can see the Delta peak in the August-September realm, and now we can see the Omicron peak in the December and January realm. So I do know that we're watching a lot of variants of concern. There is a new one that everybody's talking about, but it's not, it's the Omicron stealth variant. I think they just like to make up these fabulous names. The difference between Omicron and Omicron stealth is there is some different proteins that are harder to figure out that it actually is a variant. It's possible to be more transmissible, but in the end, we're not sure how this is going to play out. So I just want to say out loud, I appreciate everyone being so flexible. When this whole thing started, we said, this is the information that you need to know. And then we had to change, and then we had to change again, wear this mask, so I do appreciate you trying to keep up with all this information. And at any time, if you ever have any questions, please call the epidemiology department, because we want to make sure that you have all the information you need about these different variants. So this particular slide shows the most recent 7-day moving average of cases. So basically in a 7-day scenario, how many cases we've seen. And the good news is it's going down. Again, I don't want to get my hopes up like I had in the past 3 waves, but make sure that we're watching it and doing the best we can to prevent transmission. We know that it possibly can, we can get a variant that may elude the vaccines, but again, continue to promote vaccination, continue to promote cleanliness, social distancing, and all that stuff, and all the things that you've done. And again, I appreciate you all being able to pivot as you needed to. In the past, for those of you that remember, during the 2018-2019 year, we saw a huge uptake in hepatitis A virus. As you recall, this virus is also vaccine preventable. So this was something that took us off guard because there was a lessening of the vaccine being presented. So we saw a huge uptake. We saw it a lot in drug use populations, restaurant and hospitality populations, and the homeless population. So we still continue to give out this vaccine if needed. It's important, but we haven't seen a huge uptake. So these are my good news slides. That for hepatitis A, for the last few years, there have been relatively very small amounts of cases and not a lot of transmission. So again, please, if you have opportunities to talk about hepatitis A vaccine, homeless healthcare for the homeless, they push out vaccines as much as possible. So make sure that you're aware of that. Again, hepatitis A was a liver disease. Jaundice was really how people recognized that they had the disease because of the yellowing of the eyes and whatnot. And so that's really why it was so easy to spot. Tuberculosis, we still see tuberculosis in our community. The good news is that for those of you that remember, tuberculosis, it takes a long exposure period in order to get infected. So again, it takes usually like 8 hours or more of direct contact. So unlike COVID, where you can actually pass somebody by and maybe get infected, this takes a long time. In years past, we've gone to shelter operations and talked about trying to recognize folks who have chronic coughs because of COVID and other issues. I think what you can use as sort of a triage method is one of the things indicative of TB is that there's a weight loss in night sweats. So this could be something that if you're familiar with the folks that are in your care and they have a chronic cough, they may already be a smoker and whatnot. But again, ask them about weight loss and whatnot. There is blood tests that we can do that are pretty accurate to see if people have either been exposed in the past or have current exposure. So it is always been a disease of concern, but we have opportunities to treat it and find it, and that's the good news. There are multi-drug resistant strains of this, and we don't see this in the county or in the state very often, so that's good because there are other countries where we see that, and that's of concern because there are no antibiotics that can treat it. This is a bacterial disease, so again, one of those things that it's hard to treat. So we don't see a lot of cases, but again, with tuberculosis, the treatment modality is very long-term because it takes a long amount of antibiotics for a long period of time to be able to bring somebody to cure. So that's why it's a disease. We don't want anybody to be diseased, but this particular disease, it takes a long time to treat. Mosquito-borne diseases are another one that we want to make sure are concerning to the homeless population. For those of you that remember during West Nile and during chikungunya, we passed out spray to the homeless populations. We wanted to make sure that everybody was aware of it. For those of you that don't know, we have a Sentinel chicken program in Pinellas County. So there are locations in Pinellas that you probably have never seen and never knew about, where there are cute little chickens in cages that actually the mosquitoes feed on them, and then we bleed them and check and see if they have any of these diseases. So for the last few years, we have not seen a lot of activity, which is good news. We did see West Nile virus in some of the Sentinel chickens. So that is one thing we're seeing. So this is my opportunities to spread good news about some of the diseases that we're not seeing a lot of Hep A, we're not seeing a lot of TB, we're not seeing a lot of West Nile and chikungunya. But I really want to give everybody opportunity just to remind you of some of the things that we're concerned about. So the good news also is that because of the CoC, if there's anything of concern in the future that we want to let everybody know about, we'll be happy to share it with you all. And again, any questions that you can bring to bear, please do that. And that's all I have. Are there any questions?
Okay, I'm not seeing any questions in the chat. Any questions that you want to ask about any of the information that was shared by Gail? Our quiet group today. While you're thinking, I will mention, I know in our last update for emergency shelter providers, when we did our last COVID check-in, we talked about some new resources that are coming online. I will be sending out an email shortly asking about need for N95s. I think we have blankets coming in, Clorox wipes. Victoria, can you think of other things that may have been on that list?
Yeah, so there are hygiene kits, underwear for men and women in assorted sizes, lightweight rain jackets with removable hoods. There might even be pants included in that. Mylar blankets, Clorox wipes, N95 masks. I think that's the whole list.
So if you have a need for any of those items, let me know. They have the N95s now, and they can start to ship those to us. The other items, they are waiting to come in, but those are not for HLA. They're for us to distribute to all of you as providers. And I know our cold night shelters will want some of them as well. So we'll be getting that information out. We do have a question from Charlie Gale, and I'm not even going to try to pronounce that disease from mosquitoes. It was the chicken sounding one. He would like you to describe that. If you're still with us.
I am. Chikungunya. So this was the disease that we saw recently. A lot of the arboviral diseases cause things like headache, muscle pain, lethargy. Chikungunya was most notorious by having pregnant women. Their outcome was their child's head was smaller. So in some of the African communities, in some of the South African areas, and even in the United States, we saw a poor birth outcome. So that was one of the things that we saw. So a lot of them are very similar in nature. They cause joint pain and whatnot, and that's usually what we see. So what the good news is that what people will do is if they go to seek treatment, there's a panel for arboviral diseases. So they'll draw your blood and they'll check and see if you have any antibodies to any of them, and then they can there is no treatment, though. That's really the issue, is that it's just supportive care.
Thank you. Anything else? Okay, seeing nothing. Last but not least, we have some information on behavioral health from National Alliance for Mental Illness Pinellas chapter. And I think Jody is with us and going to share some information from NAMI.
Yes, hello. I'd like to share my screen if you can see my screen. Great. So I'm not sure if you're seeing my presenter view or the full screen. Hopefully you're seeing the full screen. Is it
We are seeing the presenter view, but it's not too distracting if that's the way it is going to work.
Okay. All right. Well, if that's okay, then I'll go ahead and keep it that way. So, well, thank you so much for inviting me today. NAMI is a national grassroots organization that provides advocacy, education, support, and public awareness so that all individuals and families affected by mental illness can build better lives. So NAMI in Pinellas County has been a NAMI affiliate for over 35 years. However, in 2018, our affiliate received a gracious legacy gift, which afforded our financial resources to hire some staff. So at that time, we went from a working board to a governance board, and we were able to hire 2 staff. So I'm the director of programs with NAMI Pinellas, and Denise Whitfield was hired as our first executive director there back in 2018, 2019. So in addition to our staff, we have about 60 skilled volunteers who deliver our free support programming. And we're also the 3rd largest NAMI affiliate in the state of Florida with just under about 200 members. So we're only smaller than Orlando and Miami, if you kind of look at that demographic information there. So ultimately, we want to share with the community that NAMI and NAMI members and volunteers are proof that recovery is possible. All of our 14 signature programs and 9 collaborative programs that our affiliate offers are led by those that are in recovery. So today I had intended to talk specifically about the veteran services that we offer. So I do apologize. We might have gotten our intended audience confused. So the presentation talks a lot about the veteran population because this population does tend to be the ones that come to our office that are more associated with the homeless population that we serve. But I wanted to share that we do have 2 main pathways of supporting folks, and that ultimately is the services that we provide to individuals themselves who are struggling with symptoms of a mental health diagnosis. And the second pathway is the support that we provide to their families. So we're absolutely pleased to be invited today to talk about some of the programs, but our specific program for today that I set up has to do with our veteran population. So we'll go ahead and move on to the next slide if it moves along. So this slide talks about really understanding the culture of our military service member. This is absolutely key. in that we often refer to the battle mindset when we're helping individuals understand their learned behaviors. Education, understanding, and accepting is so important as we lay the foundation for the pathway to recovery. And one of NAMI's guiding principles of support is really to see the person first, not the illness. So if you were to participate in any of our specific vet programs offered here in Pinellas County, you'll absolutely see this particular slide that I have on the screen. Recovery, according to SAMHSA, is a process of change through which individuals improve their health and wellness in a self-directed life. So we do really strive to help individuals reach their full potential. But specific on this slide, these battle mind skills become maladaptive behaviors at home, as you can see from the last column here. Individual responsibility, just as one of the examples. Each person as a military personnel is taught that they're accountable for their own survival. And then this too is really counterproductive when we come back home and then we are really faced with the guilt for reaching out for help. And that's one of the main reasons really why folks coming back from a military setting do not reach out to us here, these agencies that are presented here today. So as we go on to the next slide, NAMI has a wonderful deposit of mental health resources for our military personnel, as well as all of the individuals that might be seeking support. So NAMI Homefront has several free resources, as you can see here on the slide. We have this link too has a nice short video, a YouTube video that you might want to utilize in your waiting area or linked onto your website. We have also some great publications. So our Homefront resource directory, as seen here, was updated in September of 21, and I did share it with Amy to send out to everyone as a PDF. But ultimately, it's a 38-page directory that's hyperlinked. So it really is a great resource to have on your desktop so that it's right there on your fingertips. But you can see from the table of contents that the directory is really broken down to branch-specific resources, caregivers, loved ones, and then some of the specific populations or topics that specific to those resources. The Navigating a Crisis Guide is also extremely helpful. This does not have specific information about veterans. It is for anyone. So it's a great resource that helps an individual. It includes a crisis plan as well as an opportunity for a directory for individual telephone numbers for that individual to get connected or stay connected to their care team. You can download the PDF, or if your agency would want to purchase in bulk these guides or one-pagers, you see that one-pager there, the Navigating a Mental Health Crisis. You can easily go on to NAMI.org and get those. But thanks to donations that we receive from our community, we do have these publications, as well as a lot of other publications at our office that's located in Pinellas Park. So we'll gladly provide you with copies of these for your waiting rooms or individually for folks that you serve. Just reach out and make a plan to connect with me. So this particular slide talks about our veteran support group. We have a wonderful support group that we offer. It's called our Connection Support Group. So this one specifically is for veterans. However, we also offer a connection support group for any adult that is having some symptoms of you see experiencing some symptoms of mental health. This one particularly is just for the veterans. It's led by veterans. I have a picture here of Matt. He's one of our wonderful skilled volunteers that came to NAMI to pursue his certification as a recovery peer specialist with a veteran endorsement. And he has gained several NAMI teacher endorsements along his journey. But what's great about Matt is that he shares his impactful recovery story during our law enforcement critical intervention team training, or our CIT training, as well as our In Our Own Voice presentation. These presentations are just two examples of how NAMI provides the platform for peers to show our audience and community members a new perspective on how one can live well despite a diagnosis of mental illness and or past substance use. We're also always looking for individuals who might be interested in becoming trained to lead our connection support groups. So our connection support groups would be one of the opportunities for individuals themselves to get some support. This next slide talks about our family support group. So a lot of times we do have individuals, family members, loved ones, friends call about their loved ones, concerns that they have for their loved ones. Perhaps they are homeless or missing. It is my understanding that there is a purple alert that I'm learning a little bit more about. But this is a process for calling our local law enforcement or county officials to put out a purple alert for those missing individuals that have been determined to be of concern, perhaps homeless, but that are struggling with a diagnosis of mental illness that's untreated. So nonetheless, we have a lot of family members and loved ones that really do try to support their individuals that have mental illness or that are not living in recovery. So we do want to share our family support group. It's a great opportunity to come together with other family members. Again, it's led by family members that have been trained. So we do have the lived experience to help navigate and support the ongoing needs that are associated with someone that is struggling with a mental illness. So our family support group is really a great opportunity to ensure that we can support our family members. So next we have our NAMI Homefront program. So we really do enjoy our NAMI Homefront program, which again, this is based on our military family members and caregivers, but it is an adaptation of our evidence-based family-to-family program, which is very similar. It is an 8-week class though, to really address the unique needs of our families and caregivers. So that these family members specific to this Homefront program may have individuals that are experiencing the post-traumatic stress disorder or the TBI or other mental health conditions. So also with our Homefront, there was a RAND Corporation study that shared approximately 18.5% of service members who returned from Iraq or Afghanistan had PTSD or depression. We also had another 19% reported a TBI during that employment. So also there's another RAND study that really showed that the post 9/11 caregivers are so much more important and likely to care for those individual service members that were coming home from a deployment with mental health or a substance use condition than our pre 9/11 individuals that served. So it really does show how important it is to equip our family members and our loved ones with the supports and the education that they need to support our loved ones. So next, I talked a little bit about our peer support program that we offered. Peer-to-peer support has been an essential component for successful recovery in adult behavioral health service systems. So our workforce development program really leverages our signature programs to connect these individuals with their required 40 hours of training so that they can sit for that state exam through the Florida Certification Board. The training domains required to be taught in the 40 hours really do teach the core competencies of advocacy, mentoring, recovery support, cultural and linguistic competency, motivational interviewing, self-care, and professional responsibility. So once this individual is trained to lead one of our programs, they can immediately begin to deliver the peer-led services while gaining those 500 hours needed to become fully certified. So during that time, we also offer individual and group supervision on a monthly basis to those participants in that program so that they can meet the standards that the state has set forth for them to become certified as a peer specialist. And graciously, NAMI Pinellas has been able to cover the cost of the certification for individuals because of donations and grants received specifically for this program. And Baycare is on this call. Baycare Behavioral Health is one of our gracious donors that has helped to fund this program. So we have had, since our pilot in 2019, we have had over 25 individuals certified, and 4 of those individuals were needing help to navigate the exemption process for that level 2 background that is required for you to become certified as a peer specialist. So it really is an awesome opportunity to put these individuals with lived experience back to work in our community, recognizing that people experiencing substance use or mental health disorders who had access to peer services reportedly had more favorable outcomes regarding access to services, including but not limited to engagement, participation in services, and higher overall satisfaction. So we're really excited to be helping to put some of these veterans and family members back to work, doing some meaningful work despite of their mental health condition, because they have reached recovery. So the next slide we have is kind of our call to action or our ask. 3 things that we would love support from our community with is become a member. We'd love for you to become a member. We'd love for you to share with your organization. It's very cheap in that as an individual, if you have a financial hardship, it's only $5 annually, or there's the $40 individual membership, or a household of 4, or an organization with 4 employees, $60. So there's a lot of great member benefits that you can link to because with being a member. But second, we encourage you to connect the individuals with lived experience with NAMI. We have a ton of supports. They're all free, but also then if they would like to have some activities and brush up on some skill sets, they can be trained to lead our programs, as well as perhaps be part of our workforce development program. And then lastly, come on over and help volunteer on behalf of NAMI Pinellas. We have regular education and speaker meetings that we'd love for you to come and talk with our members. We have our annual walk, which this year is October 8th. That is our main fundraiser that helps to fund our supports that we offer. And other committees, our advocacy committees and other committees. We have our social brand ambassadors. We'd love for you to like our media pages and share our media pages. And then lastly, that office work and being there at the office so that when you all want to reach out to us to come by and pick something up from us, we'll have someone there at the office to meet you, either to mail those materials out or to be there to meet you. So that is the end of our presentation. Absolutely, we have a ton of great services and supports that we'd love to provide to the community. So please reach out. My information is there, as well as I'll go ahead and put it in the chat group. But again, for those of you on the call that are veterans, I want to certainly say thank you for your service.
Thank you so much, Jody. I did put both the Homefront Resource Directory and your slides in the chat. And we had a couple of questions come in. I think one person's looking for how NAMI might be able to assist when a client or family member maybe doesn't comply with a prescribed plan or that kind of thing. And I'm thinking you might have some family supports or resources that could assist with that.
Yes, ultimately we live in America and we have our free will. So there's so many times where our family members and loved ones don't do what we know they can in order to achieve wellness. So we really do help to come alongside those family members and help them to take care of themselves and manage their expectations and be hopeful for their loved one to begin their path of recovery. So that would be our education class, our family to family class, or our 90-minute family support group that they could come to. But also for our individual who may want to seek some peer support services, while those individuals are going through our Peers in Recovery mentorship program, we do provide opportunities for them to gain 500 hours of delivering peer support services. So it is something that is a case-by-case basis, but we have our warm line, and I can put our warm line on in the chat group as well. But our warm line is answered by a helpful peer volunteer from 9 in the morning until 6 p.m. And if you have that family member call our warm line and they have access to or have that individual that's struggling, call our helpline and ask for a peer specialist. What I will do then is I will link that person who is in need of peer support with an individual who is trying to work and receive those 500 hours, obtain those 500 hours of work. Right now we have about 35 different individuals in our program seeking hours. But at this time too, we don't receive any funding for this. So it is very informal. It is a voluntary basis. So it is just an opportunity of matching our current volunteers who are pursuing their certification with the need that the community brings to our attention. But we've been pretty good at being able to match the requests that we've had to date.
Thank you. We also had a question about training for direct service staff, and I think you are able to provide that kind of support. So
yes,
we have
yes, we do.
For the warm line phone number in the chat whenever you have a chance on that. And I think one other question that came in, I wrote down earlier was, I think many of our providers are working to ensure that folks with lived experience are a part of our system. They're informing policy, they're working alongside our clients. And so I loved some of the things that you shared for peer support and things like that. I think a lot of providers are struggling with having more peers help clients whenever maybe they have background issues or other things. Do you have any tips for how you work with that with your peer specialist?
Sure. Well, in order to be certified through the state, you do have to be level 2 and a level 2 background screen through the Department of Children and Families. And, it's important to be certified because then you all that may have a Medicaid provider number are able to be reimbursed to provide that peer support service. But I absolutely have walked many people through the exemption process. As you can imagine, I say process, there's many steps to that. And, but it is doable. It's possible to go forward with an exemption process. So please send them my way. I'm very familiar with the process. And like I said, it's doable. One thing that we do want to, or we always share with individuals who are getting ready to embark on that exemption process is that it is very emotionally draining. Remembering, unfortunately, of who you were at the time that you took and made that act is sometimes very shaming and blaming, and it can bring up a lot of triggers and cause your recovery to be in question. So nonetheless, I bring that up because it is absolutely able to be done. I actually have a PowerPoint that I've done to explain what that process looks like so that a person can be prepared for the different steps. But ultimately, the process is able to be followed as long as there has been, I believe, 2 years since the person has been released from any sanctions that they received ordered from the court as far as the consequence from whatever that charge is that disqualified them. So, there are certain criteria that you need to meet in order to apply for an exemption. But a lot of the people that we see, these disqualifying events, offenses are well over 5 or so years in the past. So that's a consideration, but certainly reach out to me. I'd love to be able to help these individuals.
Thank you, Jody. I have a question. I'm not sure if you'll be able to answer, but I'm looking around. I think we might have other behavioral health providers or the county on who might be able to answer. And it's a great question. What's the difference between the 9 to 5 phone line mentioned, the Pinellas County new single point of entry for all mental health line, and the national number? And isn't there a 3-digit number now? And so I think that is a really important question. So we all get clear on who do we refer to where and when. And if anybody has context on that, I'd love to be able to provide that answer to the group.
Well, I can certainly share from my scope in that Central Florida Behavioral Health Network, which is our main funder, funds us to have a warm line specific to meet the needs and concerns and listen to individuals who are seeking support or resource information specific to mental health. So that is the scope of what we provide based on the funding that we have. I do know that there's other numbers, the UGood number and other community numbers that have recently come about in the last few years. So I absolutely encourage anyone to call other numbers, but if it's specific to mental health, we absolutely want to be able to meet the need of that person. So, and I'm sure, like you said, Amy, there's others on the phone that may be able to talk to the other numbers.
I see Karen is on still, so maybe Karen can help us out.
Sure, and again, we are still in the very early stages. So we had an active procurement out and we're going through that process for our coordinated access model. But what that really is going to be is one number, one website, one text-based platform that people in the entire county can call for an assessment and e-scheduling to an appointment. And so the provider will be responsible for live dashboards to help indicate what wait times look like in our system for specific services. The assessment will be a level of care assessment that they will work with providers to make sure that they are providing linkages to appointments. So it's not information and referral. It really is screening, assessment, triage, and appointments. Our goal with the upcoming 988 number is really to look at how we can intersect and reduce confusion for residents for calling. So how do we intersect with 211? How do we intersect with 911? And then how do we intersect with 988? So again, we are really working that process through. This will be an implementation process with the goal of reducing confusion, adding clarity for our residents, if that's helpful.
Thanks, Karen. Any other questions? Jody, you're popular. I see a lot of people in chat wanting your phone number. So don't forget to add that here before we leave so folks can copy that down.
Yes. I'll go ahead and do that now.
Thank you. Anything else? I see Councilmember Beckman, question.
Yeah, so that previous question and comment was, what is the hierarchy of distributing these numbers to people? So if I'm doing a feeding tonight, I participate in a homeless feeding in Clearwater. And if I see someone in a mental health crisis or somebody that I want to hand off a number to, what do I give them? I mean, so we've mentioned, a warm number, a 988 number, a 211, a 911. I mean, what right now, as Ms. Yachim had said, we're working on coordinating, but what's the guidance like right now today?
So I can help answer that. From the county, our number is not live yet. So I think when we had our consultant here in 2019 and 20, that was some of what we heard when we interviewed the multiple stakeholders from the system, is exactly what you're saying, that there is an unknown place to send individuals who may be in crisis. So I always think 211 is a very good starting point. They also operate the crisis line for our community as well in partnership with PEMS. PEMS also does that. But I think 211 is a good starting point. So they know the resources, providers work in partnership with 211 to update their information. But that is information and referral. And so one of the things that we're looking to do to really elevate our system is to have the information and referral really work towards a live appointment and an assessment. And so that really is the future of where we're going. But my recommendation would be for now to start with 211. And of course, any of the local providers, most of them have open access. They have access phone lines, so again, we're trying to elevate a system and not fix something that is broken in our system. So it's really just more about elevation.
Okay. Do you have a timeline on when that should be all coordinated?
Well, we're in the procurement process right now. So we're meeting with a vendor for the presentations, and then we'll be working through negotiations. So I would say roughly, it's probably going to be a year for implementation because it's a pretty heavy lift. And it's something that really hasn't been done before. So we're going to be kind of the pioneers for the state and probably nationally for what our expectations are. Sure.
Kathleen, folks shared a number today that I think a lot of us maybe haven't heard of before, the 988 number. And that routes to the National Suicide Prevention Lifeline or the National Mental Health Crisis Line, if that's helpful. Any other questions? We hope that this was helpful today. We are looking for what you need from us for future informational presentations. So just a reminder, every other month, one month we do policy and it's in person, and those are On the opposing months, we do via Zoom informational only meetings where we don't make decisions, so that we have enough time as a CoC to share educational resources as well as wrestle with policy type decisions. So the next one of these would be in April, and we are open to suggestions and ideas. We did have one come in earlier in the chat that maybe some legal aid presentations could be helpful to understand those resources. But feel free to drop me a line if anybody has other ideas or needs, or even, you know, an idea that without a presentation, we need to spend time just talking about gaps in services. That's something that could be accomplished as well. So we are going to give you 10 minutes back to your very busy schedules. We will follow up by Monday and send all of the presentations out, as well as a link to the recording, so that, again, if your staff weren't able to attend, you can share this with them. And thank you again for everything you do. Have a great weekend. Bye, everybody.
Bye-bye.
Thank you.
Bye.
Bye, everybody.
Thank you.